All right. Good afternoon. We're going to get going now. Welcome those who are here in person and those online. This is the first lecture in the Vermont Center on Behavior and Health monthly lecture series for 2024. So happy New Year to everyone. And we're going to kick it off with a wonderful presentation from Denise Hien, who labored here, 10-hour drive through the snowstorm to be able to be with us today, and that's not an exaggeration. So I'm going to have Kelly Peck come up and introduce Denise, because he works in the same area of research. And so, Kelly, will you please come up?
Hello, I'm Kelly Peck. I'm an assistant professor at the Vermont Center on Behavior and Health. I've been following Dr. Hien's work since I was a graduate student at the University of Mississippi, so it's a real honor to welcome Dr. Hien here today. Dr. Hien received her BA in psychology from Cornell University and her 2 master's degrees and a PhD in clinical psychology from the Teachers College at Columbia University. And then received her postdoctoral training in substance use research at the Division on Substance Use Disorders at Columbia University as well. Currently, Dr. Hien, this is a long list, the Senior Vice Provost for Research at the Chancellor's Office at Rutgers, the Director of the Rutgers Center of Alcohol and Substance Use Studies, and the Helen E. Cheney Endowed Chair in Alcohol Studies, and the Distinguished Professor in the Graduate School of Applied and Professional Psychology at Rutgers University. Dr. Hien is a leader in the field of post-traumatic stress and addictions, and she and her group have conducted programmatic research through single and multi-site clinical trials across the United States in community-based substance use treatment settings with continuous funding from the National Institute on Drug Abuse and the National Institute on Alcoholism and Alcohol Abuse for over 30 years. And so for those of you who like to count, I was going through Dr. Hien's CV yesterday. I saw at least a total of 24 grants, including 7 R01s. So she has a really impressive research portfolio. Her body of work has contributed to the evidence base on effective interventions for individuals with PTSD and substance use disorders. She's published over 100 peer-reviewed manuscripts in scientific journals. She's also the PI on an NIAAA R01, a meta-analysis with individual patient data examining effectiveness of treatment for PTSD and alcohol use disorders, which I suspect we'll hear more about today. It's important to acknowledge that not long ago, the sort of prevailing thought was that you couldn't do trauma work with individuals with substance use disorders because trauma work would destabilize the individual or prompt relapse. And this narrative has changed just in the past 10 to 15 years. And that's Dr. Hien has been a catalyst for that change and thought. Dr. Hien has a long list of honors in 2023. Just in 2023 alone, she was recognized with the inaugural Mary Jean Creek Award for Underserved Populations from the College on Problems of Drug Dependence and the Award for Excellence in Trauma Services for the Underserved Policy, Advocacy, Research, and Clinical from the International Society for Traumatic Stress Studies. I personally benefited from Dr. Hien's mentorship over the past few years as a collaborator on the Project Harmony grant, which I'm sure we'll hear about today. And I'm not alone in benefiting from her vast knowledge and experience. Dr. Hien currently leads an NIDA R25 training grant for translational addictional research for racial and ethnic minority bachelor's, master's, and PhD candidates in the biomedical and social sciences. So all that to say, really excited to hear from Dr. Hien today. So please join me in welcoming Dr. Denise Hien.
Thank you so much, Steve and Kelly, for that wonderful welcome. Really heartfelt, and it made all the driving worthwhile. White knuckling it. Anyway, I'm very pleased to be here to talk to you about the body of work that I've which has been a real labor of love for the past 30 years. And more recently have been using data science as another way of advancing the field. So I'm excited to talk about that with you as well. Let's see. So the first thing I want to do is a land acknowledgement, just acknowledging that the scholarship and research that we do stands on land that is the ancestral territory of the Lenape people. And we pay respects to Indigenous people throughout the Lenape diaspora, past, present, and future, and honor all those who have been historically and systematically disenfranchised. Also acknowledging that New York and New Jersey and the United States as a nation was founded upon the exclusions and erasures of Indigenous peoples. And I also would say that the bulk of my research, the clinical trials that I've done in New York City have been in the Washington Heights and Harlem neighborhoods. And in those areas, I've had probably hundreds, if not more, participants who've helped us in our research that I always want to give thanks to when I start my work. And then, of course, all of the funding agencies that have supported the work over the career. So before I get started, I want to just also give voice to the lived experience of the people that I've spent my career working for and with, what it feels like for people who have trauma and also have substance use disorders. I know it ravages my life, but when I'm high, I don't have to feel it, the trauma, in my body, in my soul. I can disappear. A few hours, a few days, a few weeks, a break from those relentless memories. And another, well, at least I know exactly how I will feel when I use substances, good, bad, or ugly. Otherwise, I'm all over the place. So I'm going to start by talking about, the talk will take, the shape of 3 chapters. The first, I'm going to talk a little bit about epidemiology and comorbidity and its consequences. In the second part, to talk about the science of what we know in terms of integrated PTSD and substance use care. And finally, thinking more clinically about, well, how do we apply some of the knowledge that we've gained in terms of a treatment framework? So for chapter 1, this is a slide that I think everyone here is familiar with, which is the mortality from opioid deaths. This was 2021. And I think we're up to over 106,000 souls lost to the opioid epidemic. And we become aware of this epidemic more recently, but one of the things that, we haven't really, and I like to show the second slide, that we really haven't focused on are the disparities. Opioid epidemic came to our consciousness around the deaths of a predominant demographic of young white men. And that was how this country sort of galvanized around recognizing the importance of providing care and intervention for those with opioid use disorders. But in fact, African-American and Latinx populations in our country have struggled with addiction and opioid epidemic, heroin epidemic, the Rockefeller drug laws, and the prison industrial complex for decades before this opioid epidemic. And this curve just shows you more recently, and this is based on some of Ayanna Jordan and her colleagues' work, basically the curves of mortality, the curves, this top curve is sort of showing in a decade fashion the increase in number of deaths. And what you're seeing here is now the starting to taper off in terms of the steepness of the curve because of, I think, a lot of the interventions that everyone is doing around medications for opioid use disorders. But what you can see very clearly here is the curve for racial, ethnic, minoritized populations is becoming steeper, and it continues to be at epidemic proportions. So this is not something that you guys are not aware of, but I feel it's important always when you're giving a talk to be thinking about the problem. And of course, we're not only talking about death, but we're also concerned about just the number of millions of individuals in our country that are struggling with substance use, issues. And again, this is not something that, speaking to you guys, I need to spend a lot of time on. But what I want to show with this slide is really the gap between the number of people struggling, and this number is now, of course, much higher than in 2016, but only 3.8 million, 1 out of 5 people are actually receiving any kind of care. And some of the reasons that people don't seek treatment is because they're not ready. We know that. That's a good bulk, 41%. The others have to do with barriers, insurance coverage or financial coverage or other social determinants, worried about negative job effects, stigma, and, opinions of neighbors and communities. And then if we, take that into consideration, and we also then think about what about people who also live with mental illness. We know that people who live with mental illness also use drugs and alcohol, and it's to the tune of probably more than not. So a good 50%, if you go, and this is, regardless of which type of population, whether you go to the community mental health treatment programs or you go to substance use programs and you do good assessment, what we find is that the comorbidity rates are very high. And I'm going to show you a little bit of a breakdown there. But really, we have our elephant here, which is that co-occurring substance misuse with mental health conditions is really the norm rather than the exception in psychiatric populations. And yet we still, even when we think about the opioid crisis, we focus on the delivery of medications. And these are life-saving medications. I'm not saying we shouldn't be doing that, but that's sort of been the main public health intervention that everyone has been really focused around. And I think, and I talked to some of you at the center this morning about the fact that there's more that we have to do, and more about the whole person that we have to be thinking about to address the issue. And then I've written about, what I call the core syndemic, which is really, a syndemic is when multiple epidemics collide. And what we had with the COVID pandemic was happening at the same time as the opioid epidemic was increasingly in our awareness. And then we had the racism and racial reckoning that we were all going through. And those that has also been thought of as an epidemic. And then when we think about them all together, we center traumatic stress at the core. It's not the only way that you could think about how these three epidemics collide, but it is a syndemic kind of situation. And so trauma, we think about mental health, but particularly trauma is I think that's something that I'm coming to draw, people's attention to, and, what I've spent the bulk of my career working with. And so one of the ways we think about trauma is, of course, post-traumatic stress disorder. And I'm not going to go into all the features of PTSD, but just to say that it affects 8 million people in the United States, globally even more. There are high prevalence rates in both men and women, but double the rates in women. So there does seem to be some gender-specific epidemiology. And it can be caused by many things: a stressful life experience, motor vehicle accident, trauma, mental illness, but it exacts a very large toll in terms of what we think about economic burden. And in terms of the criteria, there are different symptom clusters that we're concerned about: intrusive thoughts, avoidance, HPA axis and hyperarousal and reactivity, and then negative alterations in mood. And all of these disparate clinical experiences kind of come together as the diagnosis of PTSD. And I spend a little time talking about that because substance use intersects. And when we think about how do these functional aspects of PTSD relate to a person's substance use we can think about mechanism, and I'll talk to you about that in a bit. But just in terms of prevalence, that PTSD and substance use commonly co-occur, and again, you're 6 times more likely to develop an alcohol use disorder if you have PTSD, and 2.5 times more likely to develop a substance use disorder. And similarly, if you have if you have a substance use disorder, you are, about close to half of people will report or meet criteria for lifetime PTSD. It ranges from like 30% to 40 or 50%, depending on the population. But in fact, the other thing to be focused on is the fact that you're more likely to have more than one disorder. If you already meet criteria for PTSD, you are more likely than not to also have a substance use disorder, and you're also more likely to potentially have some other mood disorder if we're thinking in diagnostic terms. So we're dealing with a complex set of problems that are the individuals who can be diagnosed with these conditions will come and present. And typically also we have medical and health problems that go along with these conditions. And so then what's the relationship between them? We certainly can understand now, and there's been a body of research that's been done looking at the kind of causal mechanisms. When I first started doing this work, we could say that there is a correlation. Like, we knew that people that had substance use had higher rates of trauma and vice versa, but we didn't really know, which caused what. And so one of the things that we were interested in was like the model. So there were kind of 2 models that were the prevailing models. One was a high risk model, which was the idea that if you were a substance user, you potentially engaged in a lot of high risk behaviors that got you into trouble. You could have been, traumatized, whether it was because of involvement in the drug or gang kind of culture, or whether it was, being under the influence, made you more likely to get exposed to either sexual victimization or crime, those kinds of things. So that was kind of the prevailing idea. The other one that, was in the mix was the idea that of self-medication, which is that people use substances to manage all those PTSD symptoms, the hyperarousal. If you take a sedative, that'll calm you down. If you have intrusive, nightmares and memories, and you, use cannabis or opioids, it will, make you stop thinking about those things that you don't want to be thinking about, the traumatic memory kind of haunting you, and so on. And so basically what we now know is that most of the the studies that have been done to kind of look at the question of which model is sort of most relevant, it's really the self-medication model that has shown that causal pathway. And we know from things like the CDC trial that looked at adult ACEs in obesity and mortality, that CDC study, which really showed that it was people's adverse childhood experiences that predicted negative outcomes much later in life. But we can also speak to a more complex understanding that includes the fact that there's a neurobiological pathway, rich multidisciplinary literature that focuses on cross-sensitization of stress and reward pathways that promote and maintain PTSD and SUD, as well as shared genetic factors. The GWAS studies indicate the role of polymorphisms as kindling in the relationship between PTSD and SUD, as well as epigenetic intergenerational aspects that have a neurobiological and genetic underpinning. So this is another way to say this is an all hands on deck problem that requires a lot of creativity for all of us. And that, I don't think one treatment intervention or one theoretical orientation or one approach is going to be the magic for, you know, what we need to do, and that we're all sort of need to be working together to try to help people, you know, solve these kinds of problems. But what we do know is that co-occurring PTSD and SUD exact a huge toll. People that have both conditions have more severe psychiatric issues. They're also less likely to actually seek help for their problems. They have higher dropout rates, increased risk of relapse. And so, you know, I don't think you needed me to make the case that it's important for us to think about what do we do? You know, how do we address these issues? But so that's where chapter 2 comes in, and I'm going to do a sort of review of, you know, the science of what we know so far. And, you know, I think we've made a lot of progress in this area. I will just mention that there's a lot, for those of you who work in clinical settings, the term trauma-informed care is something that we've also embraced. And this is the idea that, you know, the setting itself, if you have clients who are coming in who have trauma histories, we hope that the settings and the agencies kind of adopt a trauma-informed approach to addressing clients and understanding that these environments can be triggering in and of themselves. And so whatever we can do to sort of support that is very positive. So that's important information. That's not what I'm going to be talking about in this section of the talk, but I do feel like you know, it's worth mentioning. So what we know is that a phase-based approach is helpful in terms of a theoretical framework. And so we have this idea that in phase 1, what we want to do with people who have active co-occurring conditions is to do stabilization and, you know, prepare individuals for what will come in the second stage, which would be a more trauma processing model. But so within the stabilization, we're focusing on interventions that help with affect regulation. So again, back to those symptoms of PTSD where people are, you know, having dysregulated affect and cognitions. We focus on skills training, helping people label their emotional state, and also working on distress tolerance, so things like dialectical behavior therapy approaches. But that's, you know, when we first got started with testing interventions, we thought, all right, well, we got to start with the stabilization. You know, we're not going to start with trauma processing. And so the trauma processing pieces are things that you guys know a lot about. The trauma-focused interventions, such as an exposure-based approach where you're bringing the person back to the traumatic memory and you're teaching them using a guided method of systematic desensitization, basically to help have them in a kind of bottom-up approach, feel the affect, the fear that goes along with the trauma, and then help them through a process of learning that the traumatic experience will diminish over time, as opposed to if they are avoiding the experience, then it continues to escalate and they continue to be haunted. So prolonged exposure is the approach that Kelly and others have been focusing on in their research. And then we also have other cognitive processing therapies and other somatosensory therapies and EMDR. So we have a lot of approaches that do trauma processing. But, you know, when we first started doing the work, the idea was like, let's just focus on stabilization. And because back in the day, the idea was don't treat a person's trauma. If they have substance use, focus on the substance use alone. And that, you know, and then send them for trauma treatment when they're in recovery. But what we know about now about the conceptual model is that, you know, if the underlying problem is the fact that you have these trauma symptoms, treating the substance use is not going to solve the person's problems. And in fact, they will not necessarily make it through the treatment if you're not providing them with any kind of care for that. But people were very afraid that if we, you know, intervened and did stabilization work or even did any kind of processing work, then the patient would relapse and you would lose the patient, and people didn't really know what to do. So that was the idea, that sequential care was necessary, and it had to happen when they were until they were abstinent. And so you see the silos. We live in a fairly siloed world even to this day in terms of this, and I'll speak to that in a bit. But unfortunately, treating each of the conditions separately or significantly postponing the treatment of one to address the other can often lead to a worsening of symptoms. And so I have happy news to say, and that is, at this point, over 50 clinical trials have been conducted for PTSD and SUD. And we didn't know this, even as one of the groups who've been doing some of these clinical trials, didn't realize, how much work was actually out there. And one of the things that we can take away from this, which I put as fact at this point, is that concurrent PTSD care is safe and effective. So there's no question that if you address the trauma using the various evidence-based approaches that I have been talking a little bit about, and others, that we actually can and do are able to treat. And seeking safety is one of the models that we tested early on. It's a skills-based model, so it focuses on that early stabilization. It's well tolerated and feasible. However, and we've also tested concurrent treatment for PTSD and substance use using prolonged exposure, which is an integrated treatment called COPE. And that's another example of a treatment that we've used. And in both cases, these treatments lead to positive outcomes for people, reduced PTSD symptoms and reduced substance use as well. And in one head-to-head comparison of which type of treatment might work best, and this is only one comparison treatment done by Sonia Norman, showed the superiority of the prolonged exposure approach. So really the trauma processing approach as opposed to the stabilization only approach in moving the dial in terms of reducing people's PTSD. And so the clinical question of should we wait to treat PTSD when people have PTSD and substance use, the answer is absolutely no. And that combined treatments are tolerable, safe, and effective. And we see greater PTSD reductions associated with greater substance use improvement. And the opposite is less true. So the other thing is that more severe substance use may actually require trauma processing to help the person recover. So it's not simply enough to give, any kind of treatment that helps, like a stabilization type of treatment, that the person might really need that more intensive going back to the memory and reliving the memory in ways. And this is just one secondary analysis that we did in one of our trials where and the important thing to look is the gray box is the clinically significant change. And we were comparing COPE, which are the yellow and red treatment lines, and the blues are relapse prevention. So a non-trauma focused, just substance use targeting intervention. And although you see that everyone gets better over the course of the trial, which is 12 weeks of sessions, these are broken down into how much substance use the person has as they're going through the treatment. And P.S., one of the things for people who are doing clinical trials is I really, really recommend getting as many data points as you can as people are going through your study. So to be able to, even if it's a self-report measure where you're asking them how they're doing each week in terms of their substance use, in terms of their PTSD, it enables you to be able to do very nice and elegant analyses that look at, so this was a cross-lagged analysis where we looked at how the use from the week before affected the symptoms, in the subsequent week. And basically what this showed was that for those who were the most frequent users during treatment, so they were using 4 times a week during treatment, The people that got into the clinically significant range were those that got the trauma processing treatment. So as compared to this light blue, where they got relapse prevention that didn't focus on trauma, they don't make it into the clinically significant range at any point during the course of the treatment or over the follow-up period. So that just tells you, this one underscores, and this is just one example of now what we have in the literature really showing that you've got to get the PTSD down, and especially for people that are using heavily. And so it provides also the groundwork for people who are on medications for opioid use disorders and have the most severe substance use disorders, that you really do need to address the trauma in order to move the needle. And this is a shout out to your team with the idea that where we're going now in terms of clinical trials is really, since we know that we need to do these kind of trauma-focused interventions, one of the big issues is dropout, is that people don't make it through, they don't get the full dose. They still get better even if they don't get the full dose, so it's still worth doing it. But it would be better if you could get them to actually get all the sessions that you're trying to deliver. And that's where the magic of incentives come in, and the promise of incentives. So Kelly's work, built on some of the folks at Hopkins, Rebecca Schacht and Jessica Pierce, has really shown that. And so that's one really promising area, I think, for now adapting the intervention to make it better. Now that we know that these are the interventions that really work. And before I talk about the data science piece, I want to also just mention that, we do have some pharmacotherapy targets. There's not enough science in this area that really shows us. So there's a number of different agents, and I don't have time to go into all of them here, but that have been tried. And basically, we do see that there are significant reductions in both PTSD and substance use outcomes, but there's no evidence against using a medication that's indicated for a single condition. But we don't really have, like, what are the best practices in terms of medication. So it's really in the behavioral area that we have been able to show much more clearly the benefits and efficacy of the behavioral interventions. And really, because the studies are very small, these RCTs really for the FDA approved medications have been sort of womp womp. They haven't really shown they've shown a little bit of a signal, but nothing that has said, okay, here's the medication that we need to use to address these problems. However, more to come on that. So, how do we summarize this, all the body of the clinical trials thus far? The effect sizes are small. They mostly affect PTSD, so there have not been as large effects on substance use outcomes. We have problems of dropout. Our clients don't, because of all the problems that they have, it's very hard for them, and in addition to social determinants, very hard for them to make it into their sessions. They still attend if they come and they finish their trials, but there's been very spotty uptake of these evidence-based approaches in the field, and we're not able to examine inequalities and other moderators because their sample sizes are so small. So, what do we do about that? So here's one solution, is a data science approach. And so I'm going to talk about that a little bit. I know we got started a little bit late. You were going to give me a 5-minute warning, but I think I still have time. I have a little bit of time. Yeah. So this is Project Harmony. And, Kelly referred to this, but this is a multi-institution project. And what it is pooling data so we did a search to try to find all the clinical trials we could in the world and pool the data from those clinical trials in order to ask questions about comparative effectiveness that we couldn't ask with any single trial. Because again, all of those 50 trials that I was talking about, usually the for a single arm, it would be 50 participants or, 100 participants total in a 2-arm clinical trial. I think I led through the Clinical Trials Network the largest trial on an intervention in the community, and that was 350 total. So this sample is 4,500 individuals' data that we've pooled together, and I'm going to tell you a little bit more about that. This first, I have to say, my team, Antonio Morgan Lopez is my multiple PI with me on this. He's at RTI International. Don't have time to go into all the our friends and family, but these are all the people that are, have contributed their data. So amongst all of us, both our executive team and our advisory board members, I think 15 out of the 42 trials came from this team, and then we got other trials. So this is an international effort, and you see where the stars were. Most of the trials came from the US, a number from Europe, and we got a couple from Australia. And I was just recently in Cape Town for a trauma conference there, and the needing to get more coverage in the global South and other parts of the world is very important, and yet there's very little funding to be able to address. So we know very little about what's going on, but we do know that they have the same kinds of problems that we have. And so that's for future reference. I think I'm not going to talk about the overall study demographics, except to say that this is for the whole 4,200 participants in this pooled data set. It's still 65% white. We do have, the rest, are from other underrepresented backgrounds. So we have that to be able to look at in terms of the analyses that we, are doing. And, but that's an important area also, that we still need more women in these trials and more individuals. So even though my studies, they're all like more underrepresented groups than not, in the rest of the world, we basically still have this disparity, but analytically, there's stuff we can do about it. We also created an international consortium on addiction, stress, and trauma that we call CAST, and this includes all of the people who shared their data sets with us. I'd love to be able to talk about that, because that was a whole process in and of itself. But and then we classified the treatments. And again, I don't have time to go into all the classifications, but into these different categories: behavioral, whether or not they were integrated, whether or not they were combined medication with a behavioral intervention, medication alone, and treatment as usual. So we were able to take all the agnostic of the type of intervention, and these were all studies that had fidelity measures for the treatment. It was adults, so 18 and older. We had participants, they needed to have a formal diagnosis of PTSD and SUD, and then there had to be measures of both, at least at pre, post, and then some follow-up period. And that was it. So we took any treatment intervention. That's how we got so many. We found out that there are people out there trying all different things to address these problems very creatively. So I call this a virtual clinical trial. So this is where we're basically breaking randomization of each of these RCTs that we're pooling the data for. We're busting the randomization. And the way that I talk about this is like, what does this do for the findings? It does what your iPhone, when you're you've taken a picture and you have that little wand on your iPhone that allows you to click it and it just looks better, like clearer and more focused in the color and all that stuff. That's what I think these analytic techniques are doing for clinical trials. So we're using propensity score weighting and controlling for things like race and ethnicity and age and all of these variables to allow us to pool these data and actually do comparisons across those treatment categories that I'm talking about. So no clinical trial could you have 8 arms and a comparison group, and you wouldn't be able to afford it, you wouldn't be able to do it. But in this method, you're able to do that. The other thing we're doing in cleaning up the data is harmonizing, because different studies measure PTSD differently, or substance use. They use the ASI, they use timeline follow back. So you have to create some, recoding and what we call harmonization to allow you to look at the data, comparatively across all studies. But the other thing that we're able to do with the harmonization process using some of the latent model mixture approaches is to correct for measurement non-equivalence. And what does that mean? Basically, depending on who you are and what your demographic characteristics are, your PTSD scores might vary. And there may be bias that's baked into the measure. So this is like a systemic, racism aspect that we're able to correct through using certain statistical techniques. Then we're also able to take the structuring of time. So not all studies have the same, they last for, 6 months, 6 weeks, 12 weeks, 3-month follow-up. Some have a 12-month follow-up, some have a 1-week follow-up. So we are also able to make those kinds of corrections in the data set. And so what has come out of Project Harmony is, and I'll direct you, and I'm happy to share the slides as well, this is an in-press publication, PsychFull, which is a systematic review and a network meta-analysis, which characterizes the kinds of studies and how many, what the comparators are in the data set for behavioral interventions, and then the subnetwork of the medication interventions. And from this analysis, we were able to show that integrated trauma-focused treatments were more effective in reducing PTSD than comparator conditions, such as integrated non-trauma-focused treatments and SUD treatments alone. And then in comparison to placebo, pharmacotherapies that targeted alcohol use disorders with and without trauma-focused treatments were more effective in reducing alcohol use severity. So that set of findings, provided one sort of characterization of the data set, and then the follow-on study, which was published in the American Journal of Psychiatry, basically showed the comparative effectiveness across all treatment types. And I'll just draw your attention to the fact that it's the trauma-focused and alcohol targeting medication combination that has very large effect sizes in terms of reducing PTSD at end of treatment and at 12 months out. That's an estimated 12 months out. And similarly on alcohol, not so clearly on drug use outcomes. And the other thing to draw attention to is that the non-trauma focused integrated treatments like the Seeking Safety I mentioned, which we had started our career like testing the stabilization models, but there's not a lot of, I think of them as like avocados, for people with high cholesterol. Everybody likes it. Everybody likes avocados, and, but does it really impact your outcomes? Maybe not. I don't know. Don't be harsh on me about that. But so it's pretty clear from this. I think this is one of the big findings from this comparative effectiveness trial, is that it's the trauma focused approaches that you have to do if you want to move the dial. And if anything else, you can do it. It doesn't make people get worse. They might look a little bit better, but when you're doing, over the course of testing, if I were going for a treatment and I went to my doctor and I said, what should I do? There's no question at this point. So I think that's, an important finding. And so we're hoping that for Project Harmony 2.0, which is currently under review, and I'm just noting that Kelly's study is in here, we're hoping to pool in another 4,000 participants, another 22 trials, and to continue that work. And so I'm going to be wrapping up very shortly, but just in a couple of clinical comments. We think about, okay, now that we know that certain interventions work, what do we do? Like, how do we get practitioners to adopt the interventions that we know work? And there's a lot of questions that come up for clients and for providers, like how do we know what kinds of therapy to match? Worries about patients getting worse. How do I know to match? Like, what are the characteristics I should use to do matching? And so we recommend an integrated framework, which is really the kind of thing we would recommend for any complex problem, which is an integrated treatment framework that involves all of these aspects: comprehensive assessment, motivational interviewing, and harm reduction. Of course, incentivization also can be incredibly helpful, focusing on therapeutic engagement and working on skills training. And so, but the bottom line is we need coordinated care. These are complicated problems. They can't just have a single, I think you're getting that from my pitch, but that we definitely need to coordinate better across disciplines. And in some, we know that PTSD and substance use are highly comorbid and are undertreated still to this day. Integrated care is safe and efficacious, for sure. And optimal care will involve individualized ability to focus on the client and their characteristics and do collaborative assessment and combined treatments. So I'm going to stop there and have appreciation for you for listening, and all of you online, although we can't see you, and as well as all of our clients, all of my collaborators, and my institution. Thank you so much. And I think we have time for some questions. Did I get out of this?
Hi. I know that there's 2 trials that have been published in the last few years of exposure therapy with pregnant women. Both were single arm, very small, kind of more feasibility kinds of trials. Do you know of any other studies, and would you have any qualms about doing exposure therapy in terms of safety with pregnant women?
Yeah, great question. I'm not aware of those trials, but those trials we might try to pull into our Project Harmony 2.0 in the future. But I don't have any qualms. What we're trying to get over is our clients is the fear of addressing their trauma, and they avoid that through substance use and all kinds of other ways, creative ways of avoiding addressing their trauma. And so what we're trying to do is help the field get over its fear of doing the kind of treatments that actually work. And it's hard, it's painful. You're bearing witness when you're doing prolonged exposure. You're having to listen and really live through the participants' experience of what they've been through. And it's very painful, having done it many times myself. But it works. And you see people get better, like lives are transformed. It's really, so I don't want to sound like I'm proselytizing, but I didn't get into this with any kind of skin in the game. I'm not a developer of the interventions, and I've tested all different kinds of approaches. But when we know that something like this works, now it might not be a great fit for every participant or person. So we need to have other approaches. So that's one approach. There's EMDR is an approach that works very well for people, that was included in our trial. So, but yes, I wouldn't have any qualms.
Thanks for a great talk. I was really curious to hear more about your model where you presented traumatic stress at the center, racism, COVID-19. And I'm wondering specifically if you have any thoughts either in your own experience with patients or in the data how the co-occurrence of PTSD and SUD has changed at all, or treating the co-occurrence has changed since the onset of COVID-19?
So I have a couple of thoughts. One is since the onset of the pandemic, and I've talked about this with some of you also today, the field of psychology and telehealth has, because during the pandemic, people had to get creative around how they did their research and how they did their trials. And since the world allowed for this, you could use Zoom as a way, or, whatever mechanism, as a way of delivering interventions. And especially since there had been equivalence findings for exposure-based therapy, VA has done a bunch of trials looking at telehealth versus, and showing not superiority, but not inferiority. So that was a very positive thing on one level. So it's sort of broadened the possibility. So for those of us who are interested in now, how do we get effective treatments out into the world? Like, I'm not a dissemination implementation scientist by training, but I feel like in my field now, that is what we need to be doing. So I need to be spreading a clear, if the science is clear, which it is, the message that it's safe to do these interventions and they work. And so if we can do it using a different virtual, methodology to promote the access, because a lot of people in many areas, there is no one who could deliver a prolonged exposure intervention. So you're dealing with, even within an agency that has robust, ability to, they might not choose to do it because of fear, but then there's mostly the fact that there are not enough resources. There's not enough trained people who can do it. So if you can do it through some kind of an echo or using a telehealth model, that's great. So that's thing one in terms of pandemic. On the downside, I think, or maybe down or upside, we do understand that there is, and there's more work getting done on racial trauma and understanding that racism itself can be a race-based PTSD. And had been little to no research in this area. And now I think it's really burgeoning. So people are really thinking a lot more about that and understanding more about that. And I hope that the newer interventions will also be able to incorporate helping our clients to talk and think about those aspects of their lives that have just been put over here for the most part.
Yeah, great talk. I learned a lot. I'm wondering about the different types of trauma and whether you, with your large data set, have been able to sort out whether, for example, sexual trauma is more likely to be associated with PTSD or PTSD and substance use disorders.
Yeah, so great question. We would always like to be able to sort of look at types of trauma or even functional impairments, similar to like wanting to sort of be able to say that people who use alcohol have this type of profile and people who use, and it's unfortunately more random than that. It seems like it really depends. And then for the people that we see who already have both trauma, PTSD, and substance use disorders, the kinds of trauma that they have, it's not just one traumatic life event. It's like typically upwards of 7 or 8. And so they have sexual abuse. 90% of them, might report some kind of sexual abuse and childhood physical abuse and re-victimization as adults. So we're and maybe being in an accident on top of, or and racism. So it's unfortunately to parse that out. We have probably students and postdocs who will be looking at those questions. But in my experience over the years, we haven't really gotten as much out of doing types, even though we know that the more you have, the worse it is. Yeah.
One follow-up question then. What are your thoughts on the sex or gender difference in PTSD? The doubling.
Well, part of it is exposure, types of exposure. So women, it may or may not be true actually, because sexual abuse in, boys and men is a really hidden story, like it, and so it's because of gender norms, you might be less likely to find out about. But so the idea is that women or girls may have more likely to be exposed to sexual abuse, which then can lead to, is associated as a risk factor for developing PTSD. And then there's a neurobiological explanation of in terms of different hormone and neurobiological aspects that may make a person more likely, and also if there's because the similar differences in depression levels. Yeah, good question. It's
not yet. So, thinking more about dissemination and some of the issues I've run up against in disseminating treatments for tobacco and other substances, I'm wondering if you have tested or are aware of any tests of dose response in terms of number of sessions attended, and whether there's a threshold effect or what's sort of the minimum where patients actually get some benefit if the entire therapy protocol is not completed.
Yeah, great question. I didn't get to go through the whole list of the demographics of the Project Harmony data set, but about 58%, people received about 58% of the sessions that they were supposed to receive. So, you might think of that as not a very high dose, but that actually is a pretty high dose if you get at least half. All of the analyses that we look at pretty much show that getting more is better, although there are some exceptions to that, but basically, of course, getting more would be better. And so that's why studies like Kelly's and that group of incentivizing to increase the dose, so the more that you get, the better the outcomes. That doesn't mean we shouldn't still try to deliver the interventions and get as much as you can, but and also what I've seen is that a lot of patients, they don't come to every session as scheduled. So they keep coming, but they might not get the full dose because they're missing sessions, but they still keep coming. So it's still worth attempting and giving them treatment and keeping them in treatment, as opposed to some clinics that are like 2 strikes and you're out. If you don't show up for 2 sessions in a row, then sorry, you can't have the treatment, and that would be an unfortunate thing.
Well, unfortunately, we're out of time at this point, and thank you so much for persevering yesterday through 10 hours of driving in the snow. It's really been a wonderful lecture and Q&A session, so thanks so much.
Thank you. You don't want to.
Do you need your USB? You need your USB back?
Yep, I just safely eject it.
Thank you.
Yeah.
No problem.